last year. And after the great success, this is the 2.0 series that we have got now. And just a disclaimer that being since you are present in the meeting and you are attending it, so all your voice and we have already taken the consent that all your voice, video, everything will be recorded and it is shareable to us, to by us or by the third party. So I would like to call upon first our Dr. Neeraj Gupta. He is the founder of ISAS, Initiative of Sleep and Allergy and Asthma and Allergy Medicine. And he is also a senior pediatrician consulting at San Gangaram Hospital. So over to you, Dr. Neeraj. So we will start with the session now, sir. Dr. Neeraj?
Thank you, Alka. Thank you for the kind
Yeah.
invite. Good evening, everyone. So, distinguished faculty members, respected colleagues, dear friends, and participants across India and beyond. On behalf of Initiative for Sleep, Asthma, and Allergy Sciences, ISAS, it gives me immense pleasure to welcome all of you to the inaugural session of the Component Result Diagnostic Webinar Series 2.0, organized in academic partnership with Thermo Fisher Scientific. I extend my heartfelt gratitude to all our esteemed national and international faculty members who have kindly agreed to share their expertise in this important educational initiative. Your presence truly enriches this platform. I would also like to sincerely thank Thermo Fisher Scientific for their academic collaboration and continued commitment toward advancing precision allergy diagnostics and allergy education in India. Friends, allergy practice is rapidly evolving. We are gradually moving from a broad, symptom based understanding of allergic diseases toward a more precise, molecular, and mechanism driven approach. In this changing landscape, component result diagnostics, or CRD, has emerged as one of the most transformative development in modern allergy practice. CRD is not merely another laboratory investigation. It is a powerful clinical tool that helps us understand the why behind sensitization. It helps differentiate genuine allergy from cross reactivity, predict risk, guide dietary decisions, improve counseling, and in selected situations, support more rational immunotherapy decisions. However, despite its global relevance, many clinicians in India still find CRD difficult to interpret and apply in routine practice. One of the major reasons is the gap between technology and practice clinical understanding. That is precisely why educational initiatives like this webinar series become extremely important. Last year, we successfully conducted CRD webinar series 1.0 in collaboration with IAP Allergy and Applied Immunology chapter and Thermo Fisher Scientific. The response was truly encouraging and inspiring. The enthusiasm shown by clinicians across the country clearly demonstrated that Indian physicians are eager to learn and adopt precision allergy diagnostics into daily clinical care. Building upon that success, we are delighted to launch version 2.0 with a sharper clinical focus, deeper scientific discussions, and greater emphasis on practical applicability in Indian patients. I am extremely happy to share that this series has already received more than 500 registrations, reflecting the growing interest in molecular allergy diagnostics among pediatricians, pulmonologists, allergists, ENT specialists, dermatologists, physicians, and all others across multiple specialties. Over the next 3 weeks, this webinar series will cover molecular diagnostics in dust mite allergy, CRD in pediatric food allergy, peanut allergy and cross reactivity, risk stratification, pan allergens, and the practical role of CRD in precision allergy management. What makes this series especially valuable is the combination of international perspectives with Indian clinical realities. Our discussions today are not meant to remain theoretical, they are intended to directly impact patient care in our clinics and hospitals. Through ISAS, our vision has always been to create high quality academic platforms that bridge science with clinical practice, encourage interdisciplinary learning, and strengthen allergy education in India. This webinar series is another step in that direction. I request all the participants to actively engage during the sessions, ask questions, participate in discussions, and make the most of this wonderful academic opportunity. I am confident that the CRD webinar series 2.0 will be academically enriching, clinically practical, and professionally inspiring for all of us. Thank you very much. Wishing everyone a wonderful learning experience ahead. Thank you. Alka, back to you.
Yeah. Thank you, Dr. Neeraj, for the overview. Now, I would like to call upon Dr. Saibal Moitra to take over the session. Dr. Saibal Moitra, over to you, sir.
Yeah, thank you, Alka. So let me just share my screen. I hope my screen is visible to all. Am I audible and my
Yes,
screen is
you are
visible?
audible. You are audible and screen is visible.
Yes.
Please start.
Thank you. Okay, at the outset, I would really like to thank the Thermo Fisher Scientific who has collaborated with us, that is the Initiative for Sleep, Asthma, and the Allergy Sciences, in order to promote, dissipate, and also make everybody understand a very important tool, which is still in the horizon, I would say, to make it a day-to-day clinical practice, and which is definitely going to actually strengthen our hands in the order of the allergy diagnosis, prognosis, treatment, and what we call that what is going to be the future of the allergy landscape in the world and also in our country. So, in this series of this CRD, we had a similar series Dr. Neeraj Gupta just stated last year. In this series, we'll try to understand the component resolved diagnostics in a more detailed manner and try to understand that what it is, why is it that the molecules we are so much interested suddenly, and what impact it can have on a day-to-day practice. So I would be talking on the basics of the molecular allergy diagnostics today, which will be followed by some very interesting talk and the panel discussion, mainly focusing on the house dust mite allergy today. Okay. See, if you see that how this allergy diagnostics, it progressed over a period of time. So like from the time of the Blackley, when they just used the crude allergens and they saw that whether the body is reacting to it or not. So we moved on to the molecular allergy research. And with the development of the CRD and also the CRD based, the microarray tests. Now, why this important? So this is important because we need to understand that do we see exactly what our immune system sees, or do our eyes and our immune system eyes are the same and we are looking at the same thing? Because we need to see what our immune cells are seeing. And what our immune cells are seeing? Our immune cells, with the help of its receptors, it is not seeing an apple, it is not seeing an house dust mite, it is not seeing, say, a peanut, or it is not seeing a honeybee. Absolutely not. It cannot see them. Okay. What it can see? It can see the molecules. Okay. So, and by seeing and recognizing the molecules, it has some stereotyped mechanism of reacting to it, which ultimately leads on to the development of a particular disease. Now, this was a very means and thought like which was there for quite a considerable period of time, and everybody was thinking that what it is in a particular, say, a house dust mite, which is making the body react in a certain manner in some predisposed individuals, which it should not. So, is it like so something unique about these molecules which causes the allergies, or not? It is in the context which is important. So, if you remember, the Breitender was the first one who embarked on solving this mystery. He thought that let's see that whether the molecules which is actually causing the allergies, whether they are unique or not. To be very interesting to say that there is truth on both the sides. Number one, there is some amount of truth in the molecules, and on the other hand, there's another amount of truth in the context in which the molecules are being seen. Okay. So recently, I was just going through a very beautiful editorial, I think, which has got accepted and will be published in the CA by Dr. Neeraj Gupta and Dr. Soumya and Nagarajan. So they have so beautifully, they have just talked about the context, which is important for the molecules to be seen. So let's, for today's evening talk, concentrate on the molecules, okay? Because that is, in a way, it is improvising our diagnostic modalities. So what are the diagnoses? So initially, like, we thought that the top-down approach, which we still use in our day-to-day clinical practice, we take history examination, we can do a skin prick test, which is an extract-based test. There's a whole extract of the whole allergen, or we can do a specific IgE by the immunocap. It can then move on to see into the molecules of that entire extracts and the molecule-based testing, then make a diagnosis, which is a clinically driven, and we call this an inductive approach. But there's another approach to it, which is gaining more and more momentum in the days which is coming. Is it technology driven? Maybe you can say it is AI driven, the days which will come. This is called the deductive approach. The deductive approach is we start with the molecules. We start with what the immune system is seeing. And from there, we can move up and correlate it with the extract-based test or maybe the clinical history and clinical examinations, and we make a diagnosis. So as we move forward with time, the deductive approach will become more and more common in our practice. But also we say that we use a combination of the top-down and the bottom-up approach, and that is a U-shaped approach. So that is also important. So maybe it depends upon in which context, in what is our patients we are seeing, so that we can use both of them to the best of their best possible ways to come to a diagnosis and decide upon a treatment. So now you see that why we are so much interested upon the molecules. Okay. Say for this is an allergen. So the allergen source, say, let's be an apple. Okay. So this apple is made up of so many ingredients. We call that there could be carbohydrates, there could be proteins, there could be the lipids. Okay, these are the major building blocks. These are the major molecules also which make up the entire living system of this planet. But out of that, so it's not that our immune system is seeing each and everything. So maybe it's also seeing a carbohydrate moiety in the apple and it's reacting to it. No, it is looking into only certain molecules, which is mostly a protein molecule, and that too not all the proteins, but the protein of specific families, which is looking, and then it's sensing it to be something dangerous. Well, actually, I would say that means it's only in those individuals whose immune system is, in a way, it is quite dysregulated immune system or dysfunctional immune system. So that means they're more superstitious, they are more delusional immune system, like they have these delusions of they're saying that this is an enemy, so I have to fight that. So means this is actually the molecules which is saying. So that means we are coming from the source to that molecule, which is sensed by the immune system, and it actually induces the immune system to produce a specific type of antibodies, which we call an IgE antibodies. And not only it produces the IgE antibodies, it also binds to the IgE antibodies is and also gives the reaction. So we call that this is the primary sensitizer allergen, because it's causing allergy. It is not only producing the IgE, but also binding with the IgE which has been produced against it, and it is then leading on to the subsequent and allergic reactions that we see. So we move on from allergen source to the allergen, which is an entire molecule. Okay. Now, what are different levels of the allergen characterizations? So it could be a crude extract, like say you make a crude extract of the apple, or you make a crude extract of the house dust mite. So it could be, and then you do the testing. So that means that the crude extract will contain everything into it. Okay. But this is very crude. Okay. Or we can purify that. So maybe we remove all the impurities, which also can give a bystanding reactions, and we get a purified extracts. But we can, after that stage, even characterize. Okay, so this is actually what is the molecule over there. This has been the molecular characterization is done, and against this, the immune system is reacting. So we see that this is molecule A, molecule B, molecule C, molecule D in the entire allergen of a house dust mite extract. And the immune system is seeing molecule A producing antibodies to molecule A, molecule B antibodies to molecule B. So if we are using the crude extract which has content all the molecules, so whatever it is producing as antibodies to molecule A, B, C, or D, whatever it is, or maybe the entire of it, it gives a positive reactions. Or we can have only specific molecules against which it is producing the antibodies, not to the all the molecules. That is also important. And we can have a recombinant component. That is, one is the component which is from the native allergen source which has been produced, or the native molecules, or it can be produced by the recombinant DNA technology, having the same molecular structure, but to a certain extent it has been modified in a way so that it removes the certain unnecessary parts of the molecules, which could be a carbohydrate determinant, which we are not very much interested for, because it produces antibodies which is of no significance. So we only want to have only the protein molecule, that is very recombinant component. Well, we may be moving ahead, and if you know that, because that each molecule is not a single unit, it contains multiple antibody binding sites, which are called the epitope, and the antibodies which can recognize the epitope is a paratope. So we can have that epitopes also, which is the future part. As of now, we have that each of this molecule against which that the immune system is producing the antibodies. So if you see that here we are moving from the allergen source, the homogenizing. The first generation is a crude homogenized whole extract. It could be second generation purified protein extracts. Third generation to characterize the protein components. Fourth generation is the recombinant DNA technology. We have recombinant components. So as we are moving from top to down, so what is having that specificity increases more and more. True positives increases more and more. Accuracy improves. Precision of the test improves, and also the IgE profile that we find, it becomes more refined. So that means it has a more refined IgE profile, more precise, more accurate, true positives are more, and specificity is more. So specificity means the probability of the test being negative in those who do not have the disease. Okay, we do not want to unnecessarily, we want to say that, well, this is allergic to this, because they may not be allergic to this, because you have been seeing that the patients will come to you with a ELISA report, or maybe a skin prick test report, and showing the positive, and the doctor thinks, the patient thinks more, parents thinks more, oh my God, my child is allergic to so many things. But it has a very low specificity. This probability of test being positive the negative in those who do not have the disease is quite low. So this is the thing which we get as we move down tests. So it just evolved in this way. So we can have, initially we used to have radioimmunoassay, then we started having the polystyrene microwells, as you must have seen while we did ELISA. Then came the microbeads, as in the chemiluminescence assay or the enzyme immunoassay. And now we have the nanoparticle, which is using nanotechnology based CRD systems, which is being used. So just see. So this is a house dust mite. Let us concentrate for today's evening the house dust mite. So this is the dust mite. So dust mite, it can have multiple allergenic molecules. And multiple allergenic molecules, how are they named? See, this has the dust mite has a scientific name, is a genus and a species. The dermatophagoids is the genus. Pteronicinus is the species. And when these molecules are named, according to the nomenclature, they will take first three letters of the genus, that is DER, DER of the dermatophagoids, P of the pteronicinus in small, and according to in the manner in which they were discovered, you give it 1, 2, 3, 4, things like that. So that means it can have a DER P1, DER P2, maybe it can go on to have a DER P10, WP11, WP23. So these are all the molecules which has been discovered and given a name. Now you may ask that why we are so finicky about these molecules. Okay, so why we are not happy about what we have got about with this dust mite. This is because, as I've said at the outset, so our immune system is not looking at the dust mite. It is looking at the molecules. And so interaction is at the molecular level. Okay, so with these molecules, they are being presented by the antigen presenting cells to our T cells, which with the help of a billboard proteins, that is the major histocompatibility complex proteins, mainly because of the class 2. So then a helper T cell recognizes that with the help of a T cell receptors. And these are the molecular interaction which takes place. And depending upon the uniqueness of the protein molecule, it then drives the reaction in that particular naive T cell in the context. Again, in the context, which is context is determined by what? Many things. It is determined by the microbiota, by the cytokine profile, by the chemokines, by the other cells in the surroundings. So there's so many things, and now we have the EVs or the extracellular cycles, which decides the context. So when we talk about the molecules, and we have come to the protein molecules, with the various families of the protein molecules. This is by what is the biochemical nomenclature. So it could be lipid transfer proteins, the storage proteins, the tropomyosins, the profilins, the serum albumins, and lipocalins. Why interesting to know the families? See, these protein families, a huge number of the protein families. But it has been seen out of the huge number of the protein families, whether it's animal origin proteins or the plant origin proteins, there's only a very small number of protein families which can elicit an allergic reaction. You know, Breitender was very much taken up by this. Why only this small number of proteins out of this huge number of protein families? What's so unique in this small number of protein families? What's so unique in lipid transfer proteins? What's so unique in the tropomyosins? What's so unique in the profilins? What's so unique in the lipocalins? So that it is giving the allergies in the particular context. Why not the other? That is still an enigma. And I think this enigma has to a certain extent got resolved by the various techniques like the nuclear magnetic resonance, the NMR, spectroscopy, or the mass spectrometry. This is unraveling the way the unfolding of the structure of the beta pleated seeds or the alpha helices. It has occurred in these molecules. It is actually causing these entire T cell receptors to actually, which is also dependent, as we all used to say that it's all the context, but it's also a stoichiometric stoichiometry means the alignment of the various molecules. It also has a very much impact on how this T cell receptor sees it. We all know that adaptive immune system is extremely specific to the sense that it can even identify a change in the one amino acids. Okay, so that means that specificity, if it is recognizing that, we understand these are the proteins, these are characteristic of the proteins, and this is driving the reaction, and this is how we are going to make it that is makes it more specific. So we come from the extract level test to a molecular level test. Molecular levels, we have lots of advantages. It's stable form in large amounts, free from the cross-reactive carbohydrate determinants. We have accessible epitopes and things like that. So just a short about this CCDs. See, this is various protein molecules. Okay, this is say of AL1, AL2, AL3, AL4, many up to this. And this is, you see, these are the CCDs, okay, which is attached to it. How the CCD comes? The CCD comes because of the post-translational glycosylation or fucosylation. This is a modification in the protein structures, which gives them certain function which is important for the survival, and which has a very important role in the survival of that of maybe the plant or that organism or whatever it is. So if certain antibodies is binding to these CCDs, it will still become positive. So, but it's actually false positive because it is not binding to, you can see the not this as protein molecule. So to remove this, if we can have the CCD inhibitor, which is so that all the CCDs are then inhibited by this, so that you can directly bind to the allergen molecule and give it a positive. So this is how the CCD inhibition affects. We can see this is a type of the test we call the Allergy Explorer platform. So without so many bright spots, so many positivities. But if you see this sample test, so many positivities you can see, but when a CCD inhibitor is given, there's so little positivity. But here, we are not finding much difference between the two. So that means here we can say that majority of the wells they were binding to the allergens. But here is majority is binding to the CCD. So that is how we just find it out. So we talk of molecules, and these are the molecules, how it is being recognized. And so what is the application? It is very important. Where others stop, the CRD starts. What does that mean? That means is where everybody just stop at seeing the sensitization or the reactivity to the crude allergen, and done with the clinical correlation. CRD starts after that. CRD dives more deep. Okay, and it says that what is the structure of that molecule against which is the actually it is the immune system produces the antibodies. It is important for the risk stratifications as we're talking about the food allergies in case as when we talk in the next section. But there's a rule of thumb. Always remember those proteins which are heat stable or the digestive acids, they cannot break them down, they're more stable to the digestion, they cause the most severe reactions. And those which are heat labile and can be digested easily by the acids, they usually cause the less severe reactions. Okay, so this is important because CRD improves in the risk stratification. We know that there is a risk stratification scale or the severe clinical severity scale of each and every molecule, which states that the being positive to this molecule, what is the chances of the patient going into a very severe reaction? And that is all these molecules we know because of their reactivity and its more clinical they're very good clinical correlation. It states that we can know this. If it's positive to this, we can say that yes, this is quite right, it can cause severe disease. Or if this is causing positive, this molecule is positive like TERP1 or TERP2 or TERF1 or TERF2, then correlate it very easily with what is called the clinical disease. But there can be certain proteins which are present in many of the means the animals. Also, these are quite common proteins. They're tropomyosins. Okay, but this topomycins in positivity means what? It means that for say for the another say for somebody is having a shrimp. The shrimp also has a topomycin. Dust mite also has topomycin, that is the WP10. And but if somebody the topomycin has been produced with the house dust mite, it has caused the immune system to understand it and take it as an enemy and produce a topomycin antibodies. But the shrimp, it is just if by eating shrimp, since the antibodies are similar to that of the tropomyosin of the house dust mite, the antibodies react to it. So it has not directly caused the immune system to have an antibody against it, but it is only reacting to it because of the molecular similarity. So this is what is called a cross-reactive molecules, which is usually carries no clinical significance. So this chart is showing a severity analysis and risk stratification of the various allergens, which is best we can only understand if we are doing the CRD. This is just we're talking about the genuine versus cross-reactive sensitizations, the tropomyosins, and this is for the dust mite, the shrimp, and the cockroaches. And these are the important, that's the BLAG7, WP10, and the PENM1. So we know that whatever these molecules has a prognostic implication as well. So when you talk about the FLD1, it can cause asthma. So if we talk about the W1, if we talk about this as W1, W2, WF1, WF2, it causes the asthma. And if the WF2 and WP23 chances of severe asthma is more. And if we talk about the WP11, it is usually a house dust mite driven atopic dermatitis. So things like that. And we all know that this so interesting phenomenon, this entity that is the food dependent exercise induced anaphylaxis or the cofactor induced anaphylaxis. This is for omega 5 gliadin or the tri-19. So these are very interesting. These are the molecules just giving rise to particular disease. So benefits, this stratification, macro genuine sensitization, indicator cross-reactivity. Suppose the choice of the AIT, very, very important. So if we have to know what our AIT contains and what the patient is sensitized or the allergic to sensitized to, if we can say, allergen prevention molecular spreading, an entity which we see very often in the topic march, where more and more molecules, the immune system starts taking it as dangerous molecules producing antibodies. And this occurs because of a very important concept in the immune system, which is called the epitope spreading, leading on to the molecular spreading. And it can happen when there is more actually activations of the genome and epigenetic changes leading on to the more and more dysfunctional immune system having and disease spreading into more in a pan allergen spreading. This is not a good thing to have. So eliminate interference, detects anaphylaxis, and obviously immunotherapy guidance. So this was in a basic, I had just talked about that what is the molecularology and how it interprets the molecules and what it's important to have. So I hope that with this basic understanding, we'll move forward and have the other sessions. This is the QR code. This is for the registration of our organization, as I've said, that initiative for the sleep, asthma, allergy sciences. This is one of the most valuable platform, pragmatic platform, and it is, we can call it an ISAS ecosystem, which we are building, having those people from the international repute and the national repute will be coming together mainly for spreading the knowledge and education in the field of the allergy sciences. We already have crossed a lot of members, more than 1,000 members. The membership is still free. You can just click on the QR code and become the member of our family so that we all grow together. Thank you.
Thank you so much, Dr. Saibal, for the insights that we got into the basics of molecular allergy. Now moving on to next session by Dr. Krishna Mohan, and introducing Dr. Krishna Mohan. He is a senior pediatrician and pediatric allergist from Health Services Kerala, and he will be taking the session on molecular profile of house dust mite allergy. Over to you, Dr. Krishna Mohan.
Yeah, am I audible?
Yes, sir. Yes, sir.
Okay, so thank you so much, ISAS, for this wonderful opportunity, especially my dearest friend, Dr. Neeraj Gupta. And thank you so much, Saibal sir, for setting up the ground. I think you have covered almost 50% of the topic. So in the next 20 minutes, I will be talking about the molecular profile of house dust mite allergy alone. So why discuss this topic, molecular profiling of HDM? Because we all know, majority of us listening to this are allergy specialists. We all know house dust mite is the most common indoor aero allergen sensitization worldwide. And it is associated strongly with allergic rhinitis, asthma, atopic dermatitis, and majority of our allergic comorbidities. Not only that it directly causes these diseases, but it is also a major driver of persistent airway inflammation, and it can result in the severe asthma phenotypes and all the multimorbidities of allergies and asthmas. So traditionally, as Dr. Saibal has just mentioned, we were using and we are still using skin prick test as well as the specific IgE test like immunocap for diagnosis. So although these techniques can really help us in identifying the sensitization, they have some disadvantages. Uh, they do not adequately distinguish between genuine sensitization and cross-reactive responses, as you just saw in that picture where Dr. Saibal was telling about the cross-reactivity. Also, they do not identify the specific allergenic molecules associated with severe disease. We cannot predict which disease is more likely to become more severe. Also, it cannot predict therapeutic responsiveness, especially when we are planning an allergen immunotherapy, how the prognosis will be even before we start the immunotherapy. So CRD may help in all these things. So house dust mite, as all of us know, they are microscopic arthropods belonging to the Arachnidae class. If you see that family diagram, starting from the kingdom Animalia, going down, they have a lot of very close relatives, cousins like. So all this you can see in this picture, these spiders, scorpions, these prawns, all these things are their cousins, they are close cousins. So these allergens in HDM, they are primarily derived from the fecal pellets, the bodies of the mite itself, the secretions and enzymatic proteins. It is a mixture of all these things. And the allergenic components, when we are talking about the house dust mite alone, now we know there are more than 40 allergenic components. There are different species of this house dust mites, and each of them are having 30 to 40 different allergenic components, and they differ greatly in their molecular structure, their function, their potency, as well as the clinical relevance. We will be discussing each later. So this is the WHO classification of allergen nomenclature. So basically, to talk about the house dust mite, they have mainly the class 1 allergens, the DER P1 as well as the DER F1. So if you see the reactivity, IgE reactivity to these allergenic components, you can see they are causing very much IgE reactivity in the range of around 80 to 90%. So coming to the group 1 allergens, so the DER P1 as well as the DER F1, they are considered as the group 1 allergens, and they are responsible for the majority of sensitization of the house dust mites. They are basically cysteine proteases. They are not just allergenic components. They can be considered as biological weapons, because if you see the biological functions, they causes several pathogenic effects. They are the starting point of the destruction. So they start cleaving the epithelial tight junction, thereby increasing the epithelial permeability. This facilitates the allergen penetration. And not only that, it activates the pro-inflammatory pathways, promoting the Th2 sensitization. So in simple terms, these group 1 allergens like DER P1 and DER F1, they can cause airway epithelial injury and enhance the allergic inflammation. Clinical relevance, it is strongly associated with persistent allergic rhinitis, asthma, early childhood sensitization. So this is the starting point of sensitization. When we are talking about house dust mite, this particular allergenic component is the leading cause of the start of the allergy these days. So early childhood sensitization, and majority of them are associated with the severe airway disease. So DER-P1 and DER-F1 is considered as a marker of genuine HDM sensitization and is particularly important in identifying patients who are likely to benefit from allergen immunotherapy. So that is about the class 1 allergens. Now coming to the DER-P2 and DER-F2, their reactivity is also in the range of 90%. They are considered as the group 2 allergens. So these group 2 allergens are lipid binding proteins. They are structurally similar to the MD2, a component of the TL4 signaling complex, TLR4 signaling complex. So what is the immunologic significance? They can mimic MD2 and it can facilitate the TLR4 signaling. If you remember the basic pathophysiology and immunology of allergy, you may be remembering all these terms. So it enhances the innate immune activation. So this ability may contribute to its potent allergenicity. When we discussed about DER-P1, which is a class 1 allergen, that was the starting point of sensitization. But DER-P2 and DER-F2 are considered to be more potent allergenically. The allergenicity is more potent here. So what is the clinical significance? DER-P2 is recognized by a large proportion of HDM allergic patients and is highly associated with severe allergic rhinitis, persistent asthma, and all other severe allergic diseases. What if you get both of these together? So a combined sensitization to DER-P1 and DER-P2 strongly indicates a genuine HDM allergy. Now coming to another important allergenic component of house dust mite, which is coming up largely nowadays, DER-P23. So DER-P23 is a emerging major allergen. It is a peritrophin-like protein associated with the peritrophic matrix, the mite fecal particles. So the clinical association, this DER-P23 has been linked with childhood asthma, severe allergic disease, persistent airway inflammation, and polysensitized patients. So sometimes you will get this isolated P23 sensitization also. So some patients demonstrate strong sensitization to the DER-P23 and with negative DER-P1 and P2. So this simple finding has significant implications for extract-based immunotherapy because majority of the extracts which are available conventionally are revolving around DER-P1, DER-F1 and all, and not about DER-P23. So there we are not sure about how much is the content of DER-P23 in the available sublingual allergens. So these are some of the other clinically relevant house dust mite allergens. So DER-P5 is there, which is associated with severe varieties of asthma. DER-P7 is there. DER-P21, it is also considered as an important marker of severe asthma and complex molecular sensitization patterns. These three, that is 5, 7, and 21, are considered as the class 2 tier antigenic components. Another thing is the DER-P11. So this is a paramyosin molecule, which is associated particularly with atopic dermatitis and skin barrier dysfunction. So suppose you are getting a DER-P11 positive in an atopic dermatitis patient, that is significant. So that is regarding the different allergenic components of house dust mites. So this is one very interesting article, the molecular sensitization pattern to house dust mites from first years of life. They have studied the sensitization pattern starting from the first year of life, and they have continued it till 50 years of age. So what you can see in this picture is that when you are starting with sensitization at 1 year of age, first, to start with the DER F1 and P1, it was very high, whereas F2 was a little bit lower. But as age advances, you can see the sensitization of the F2 is increasing. And after a particular age, this P23 is also becoming a significant allergenic component. So as I already told, this is the beginning point of the sensitization with the F1, and later this F2 comes, and then F2 will be predominating. So being in India, we need to discuss regarding this thing also, that is Blomia tropicalis, the storage mite. So especially in tropical countries as well as subtropical countries like in our place in India, sensitization to Blumia allergens may be sometimes equal or sometimes they exceed the DP and DF sensitization. So the major Blumia allergens you should remember, blow T5, blow T21 and blow T2 are the allergens. Whereas we also have the cross-reactive markers like blow T10 and blow T20. We will discuss it when we discuss the cross-reactivity. So these are the some of the different allergenic components of house dust mite which is commercially available. So we know for DP we have P1, P2, P5, P7, P10, P11, P20, P21 and P23. And similarly for DF also. And for the storage mites like Blomia, Lepidoglyphus, Glyphosophagus and Tyrophagus also we have the different allergenic components which are available. Now coming to another important, interesting concept, cross-reactivity in the house dust mite. So cross-reactivity is nothing but when the IgE antibodies directed against one allergen recognize structurally similar proteins from another allergen source. So as far as this house dust mite is considered, there can be different types of cross-reactivity. There can be intra-species cross-reactivity when the DER-P and DER-F, they are very closely cross-reactive. It is around in the range of around 80 to 90%. There can be inter-mite cross-reactivity different between the species also, like dermatophagoids and Blomia. Compared with DP and DF, that cross-reactivity is comparatively very less. There can be another type of cross-reactivity in between the invertebrates, like house dust mite can cross-react with the shrimp and cockroach, etc. I will come to that later. So this is an interesting picture which demonstrates how far the house dust mite allergens can cross-react. So coming back to the same picture again. So what is the reason for this cross-reactivity? So I already told everything started from the same kingdom, the same phyla, and it has come down. Through the millions of years of evolution, they has finally reached the dermatophagoids or the house dust mites, where they have very closely related relatives or cousins like the spiders, scorpions, shrimps, all those things are very closely related when you consider the evolution. So there is something which is called as the pan-allergens, which is having a very important role in the HDM cross-reactivity. So these are proteins which are widely distributed across unrelated species. So what is the reason for that? So there are certain components in the body of the house dust mite which were highly conserved during evolution. The reason for that is that they had critical roles, very fundamental roles in the cellular and muscular function, and just because of that, evolution has preserved these components. Three important such components are: one is tropomyosin, second is arginine kinase, and third is the paromyosin. So these are components which are present in the different group. So you just remember this picture, starting from the arthropoda, coming down, these important components are preserved. So tropomyosin will be there, arginine kinase will be there, paramyosin will be there in the mites, insect or shellfish. If you take these components may be present in majority of these different group of organisms. So that is the reason why they cross-react. So tropomyosin is a muscle protein which is found in mites, shrimp, crab, lobsters, cockroach, and parasite. And the tropomyosins in the house dust mite, when we do the CRD, we get DER-P10 or DER-F10. In Blomia, we get BLO-T10. Whereas the closely cross-reacting one in the other insects like cockroach, we get the BLA-G7, and in shrimp, we get the PEN-A1. So these are all cross-reacting allergens. So if you are doing a skin prick test or an immunocap to the whole allergen or the whole extract, you may sometimes get a positivity to this shrimp or to a cockroach, even though they are not sensitized to this. So sometimes you may get a shrimp positivity in a purely vegetarian person who has not at all exposed to a shrimp. That or the reason may be the presence of tropomyosin in this house dust mite. So that is how they cross react. So this is one very practical diagnostic algorithm for suspected HDM allergy. So it differs when we compare the temperate countries and the tropical countries, because in tropical countries we have the blomia and the other storage mites also. So this is a very simple algorithm. If you can see those presenting with asthma or rhinitis symptoms, if you do a skin prick testing or immunocap, we are getting either it's positive or negative. So once you get a DP or DF positive, then sometimes you can do a CRD with the major allergens like P1, P2, P23 and DER P10. So if you're getting this P1, P2 and DER P23, then it is taken as positive and it will guide you in deciding whether to choose an immunotherapy or not. Whereas if you're getting a negative values for P1, P2 and P23 and a positive value only for DER P10, it is possibly a cross reactivity. Their immunotherapy is not required. So that is how the value of doing a cross component result diagnosis will guide you in deciding whether to go along with an immunotherapy or not. Similarly, if blomia also is there in your place, like in many of the tropical countries, there also the CRD will help you in deciding whether to start immunotherapy or not. So that is how the knowledge regarding cross reactivity will help you in taking very important clinical decisions like starting or initiating an immunotherapy. So that is in short regarding this presentation of molecular profile of house dust mite allergens. So as Dr. Saibal Mitra sir has already displayed, this is the QR code. Those who are interested in joining this wonderful organization, the organization with the maximum number of members of the allergy aspirants in India, it is reaching around 2,000 by a mere span of around 2 to 3 months. So those who are interested can simply just scan this QR code and become with it. It will take only minutes to join the organization. So the complimentary offer for membership will be there for the next few weeks. After that, it will be charged. So please do join ISAS. So thank you so much for your patient listening. If you have any doubts, we can take or we can discuss at the end also. Thank you.
Uh, Thank you so much, Dr. Krishna, for the wonderful session on the molecular profiling of HTM. Now we are moving on to the next topic by Dr. Karthik Nagaraju. He is a pulmonologist and allergy sleep specialist and has a fellowship in allergy and immunology from IACI. And he also has IACI certificate in allergy and clinical immunology. So he'll be taking a session on clinical implications of HDM components in Indian practice. Over to you, Dr. Karthik.
Thank you. My voice is no better, right? I had some
Yes, yes.
yeah.
Yes,
Perfect.
yes,
Thank
yes,
you.
yes.
Great. Super. So thank you so much, Alka, for the introduction. Thank you so much, Thermo Fisher team, for the organizing this very interesting and need of the hour learning series for for India. And as Dr. Neeraj sir said, about why this we need a component result diagnosis module or molecular allergology module in India, is that we have for few years until a few years ago, we were quite behind the Western practices in allergy, and their standards of practice were quite different. And what we see is that since the introduction of component result diagnosis in India, we have nearly matched international standards. We have a better understanding of what happens in India, and how we are using them in India has also become an evolving strategy. So my topic today will be focusing mainly on how we can use house dust mite component knowledge and in our day-to-day Indian practice. So I will be focusing mainly on the overview of the components. Sir has already given a very detailed explanation, probably just a brief introduction. What is the sensitization profile in India and how is it changing over the years, and what has component distribution made a difference in our understanding. What are the clinically relevant components and what is the significance of each component? Sir has given brief introduction on what each component means, but what is the clinical meaning of a clinical outcome, or does it impact anything, or does it make any difference? Is there any implication with diagnostic tests, or is there any implication with therapeutic interventions? And when do you include CRD when you're considering host test mite allergies? So we know that nearly 10% of the population, which is 800 million people, are affected by allergic rhinitis and asthma worldwide. And anywhere between 40 to 85% are attributed to house dust mite sensitization. The example here is that this is a pediatric allergic asthma case where there are nearly 68% of the cases are secondary to allergic asthma. In that, nearly 50% of them are due to house dust mites, while this contributes to an increase in the persistent symptom burdens, affecting the quality of life, school absenteeism, and academic performance. And also, as a progression, because of daily persistent exposure, we progress from simple rhinitis to a perennial rhinitis to asthma, or even we have a reverse atopic march coming up in the adults also. Uh, Per se, there is a huge variation in how this dust mite sensitization or allergen burden is distributed worldwide. If you look at Southeast Asia or just Asia itself, there is a huge difference. And when you look at India alone, you can see that there is there's a huge difference between what is the sensitization rate. More than 80% are sensitized in South India, whereas in Northern India, it's nearly around 40 to 60% range. The data is huge variability. We'll be talking about that also a little down the lane. Sir also gave a brief introduction about how all the dust mites belong to the Acari order, and they're all they have different families and different genus and different species. The ones that are most important to our clinical outcomes are worldwide are Dermatophagoides family, genus actually, and there the Dermatophagoides terronicinus is DERP, Dermatophagoides farinae, and we have the Dermatophagoides microceres also. These are the top 3 common Dermatophagoides reported worldwide and in India also. And however, we have the rest of the dust mites, which are species called Acaris, Tyrophagus, Lepidoglyphus, Blomia, are all part of what is called as storage mites. And there are some cross reactivities between these families. So, and depending on the regional distribution, there is a difference in who has a higher storage mite exposure and who has a higher house dust mite exposure. So in India, there is already, like, we have both a temperate zone and I'll just choose 1 minute. Yeah, we have a temperate zone, and we have a tropical and subtropical regions, which are coastal, central, sub-Himalayan regions. We have dry regions, desert regions. So there's a huge variation in the geographical, presentation in India itself. And as such, we have definitely in India higher temperatures compared to the rest of the world. We have higher relative humidity, predominantly in the coastal area. So dust mites thrive in such high temperatures, and as a result, dust mite can survive year long in such temperatures, even in summers or in winters, and particularly in monsoons. And sometimes this variation occurs in the northern part of India, sometimes in eastern, and more there is not much of a difference when it comes to southern part of India. We have difference in which dust mite is also predominant in different regions. This is like, for example, we have predominantly Dermatophagoides terronicinus, which is predominantly seen in the coastal parts of India. There is a lot of Dermatophagoides farinae, which is reported from the northern part of India, which is more in temperate zones. We have a higher incidence of Blomia tropicalis reported from the eastern and the coastal parts of India, and where are heavy monsoon seasons available. So, and we know that 70 to 80% of bronchial asthma in India are sensitized to dust mites. So we need to know that just labeling somebody as dust allergy, we have evolved from looking at dust hypersensitivity to looking at what dust mite allergy is there, and what particular component is also contributing to the allergy is now our understanding using component resolved diagnosis. We have in India, we also have plenty of urban slums. We have a lot of cockroach availability or mixing with our living with our population. We have variation in the seafood habits also, particularly along the coastal regions of India. So there is a lot of this sensitization and cross reactivity or cross sensitization to other foods and other proteins, as what Dr. Krishnamohan has heard and said. This varies region wise. This is a paper that looks at the various studies that have been performed between 2010 till 2020. I could see that most of the studies used skin prick testing extracts for diagnosis, and they found that among the three top dust mites, Dermatophagoides tyronicinus and D. farinae, are the most common across India. Central India has a reported lower number, and only one study has looked at specific IgE measurement. And if you look at Plomia tropicalis, it is highly variable. Some centers in central parts of India have a lower rates of sensitization, and centers from eastern and coastal parts of India, like South India, like our center, we have nearly 60 to 70% of the patients also quite co-sensitized with Blomia tropicalis. This is something that we also looked at in our center in 2025, where among 740 patients with perennial allergic rhinitis who underwent DPDF or Blomia testing, we had nearly 54% of the patients had Blomia also. And when you look at partly or uncontrolled asthma also as a diagnosis among 480 patients, we had nearly 49% of the patients were also Blomia tropicalis sensitized. So there is a significant difference, and this persistent sensitization is noted across dust mites, 3 different dust mites, and we need to understand that Blomia tropicalis is also an important dust mite to be considered when evaluating for dust mite allergies. So sir has already told that there are 40 different allergenic proteins identified, but among them, the top 3 are the most clinically relevant ones. We include your DERP1, DERP2, and DERP23, which is a group 1, group 2, and group 23 allergens are the top most important and suggestive of genuine sensitization to dust mites, particularly DERF and DERP. Why DERP1 and why not DERF1 separately is being discussed is because there's a high cross reactivity, nearly 94% cross reactivity between DERP1 and DERF1 and DERP2 and DERF2. So you need not test for components for DERF if you have a suspicion for dust mite sensitization. So among the important components, again, I'm just reiterating that group 1 and group 2, nearly 80% of the population have high sensitization with group 1 and 2. But group 23, which is DERP 23, is also a significant one, present in more than 50% of the population. Coming to the clinical relevance of house dust mite components, Sir has already told that DERP1 or DERF1, which is the first group 1 proteins, are nothing but cysteine proteases, and they are generally responsible for cleavage of the tight junctions. And now we need to understand that DERP1 could be the primary instigator for further development of future allergies down the lane. So sensitization at an earlier age to DERP1 predisposes to higher sensitization to the subsequent components, which is what is called as DERP1 to DERP2 to DERP10 to DERP23. So gradually the number of molecule sensitization keeps increasing as we age, and this is what is called as molecular spreading. And the inciting agent, or sometimes is most likely something that causes the first barrier to get affected. This is affecting not only the respiratory barrier, but also the skin barrier is also affected in these patients. So DERP1 becomes a very important component in these matters. DERP2, again, because of its high homologous structure homology to MD2 and TLR4, actually is capable of generating a larger TH2 mediated inflammatory response. So if a small quantity of DERP2 is capable of binding strongly with a TLR4 receptor and capable of developing a powerful or a large inflammatory response. So that is why as time goes, there is a stronger DERP2 sensitization with age or with increase in symptoms, which leads to persistence of allergy, persistence of asthma, small airway dysfunction, difficult to control asthma, or even severe asthma also. The third component, which is most important, is your DERPI-23. This DERPI-23 was until recently considered a very minor allergen, but then it has been proven extensively with several studies that's a very important allergen. What DERPI-23 does is it is excreted in the fecal pellets of dust mites, and has been shown that nearly 50 to 80% of patients, with nearly 74% in one data, showing that they are sensitized to DERPI-23. TP23 not only causes the same epithelial barrier dysfunction, but also causes a strong epithelial damage, which leads to subsequent T2 inflammatory response, like elevated fraction of exhaled nitric oxide levels, and also for elevated blood eosinophil levels has also been correlated. What is interesting is DERPI-23 is less present in extracts, but what we need to understand is DERPI-23 is also less present in the fecal pellets. So when we extract, the concentration of DERPI-23 in our aqueous extracts are less. But DERPI-23, even in small quantities, is capable of generating a large mast cell activation as much as DERPI-1, which is because DERPI-23 is 10 times potent than DERPI-1 sensitization. And that is why DERPI-23 sensitization is more associated with more airway involvement, more severe forms of diseases, more eosinophilia, and more pheno also. What we need to understand is there is more than 3.38 times more likely to develop asthma, and DERPI-23 itself is an independent predictor of early asthma or severe uncontrolled asthma development. Coming to component, the cross reactivity, because house dust mites have several components which are also called DERPI-10, which is the most common cross reactive pan allergen. Sir had already given an example about how this tropomycin is present across several species, and that's why we have several patients who have a shellfish allergy also reporting airway symptoms, or patients with airway symptoms reporting a shellfish sensitization or sensitivity on consumption. So this seafood house dust mite or mite shellfish cross-reactivity is commonly noted with tropomycin, but is also to be importantly considered is arginine kinase, or DERPI-20 is an important allergen that we need to look into. DERPI-20 is present in both insects, shellfish, and also in dust mites. DERPI-20 is also a strong allergenic protein, which is capable of causing allergenic response on its own. It is being, we are understanding better about DERPI-23 as time goes by, but we need to understand that just because somebody is sensitized, we can now understand, are you DERPI-10 positive, are you DERPI-20 positive, and what is the reason why you have both a shellfish or a co-sensitization, or a both positivity to insects or shellfish or dust mites in your testing. We did a study among patients with perennial allergic rhinitis and bronchial asthma in our patients, where nearly 378 patients were selected, and they underwent component resolved diagnostic tests, including all the 4 components were tested in all patients. We noticed that DERPI-23 was the most common sensitization in our data, which is 56.9% patients, and DERPI-10 sensitization was noted in 12% of the patients with perennial allergic rhinitis with or without asthma. But when we started to look at patients who had severe disease, we noticed that those patients who had severe disease had a higher incidence of monosensitization to DERPI-23 compared to DERPI-1 or DERPI-2 in our patients. We also looked at why DERPI-10 positivity was there, but although nearly 12% of the patients had DERPI-10 positivity, only 4% or 4.2% patients had a history of shellfish reactivity, which means just because DERPI-10 is positive, it does not always mean that shellfish reactivity is present, but it can explain in the presence of a history that there is a possible explanation. And DERPI-23, like I said, is associated with the severe forms of allergic rhinitis, allergic conjunctivitis, bronchial asthma, and a higher pheno in our data also. Now let us look at what is the data from Europe also. And when we look at Europe, we know that similarly DERPI-1 and DERPI-2 have a higher 80% and above data, and nearly DERPI-23 also is quite high. But if you look at DERPI-10, it's also very similar number reported from European data also. Although the percentage of shellfish reactivity is much lower in European population compared to our population. So why conventional extract testing fails, and why component testing as added value? We'll just build up a story for that. Let's look at it. And we know that extract testing gives some sensitization, but it does not correlate with symptoms. It can, the size of the SPT reaction or the value of specific IgE can correlate with the likelihood of allergy, but it cannot correlate with the symptoms of the patient. And this is where its biggest drawback is. And if you're monosensitized to any particular allergen, let's call DP, it does not give any clarity on what allergen component is the driving the allergy for this patient. It can also not separate cross reactivity, like how sir has already told, between dust mites, between dust mite and insects, and between shellfish and dust mites. The problem here is also added that Indians have a higher total IgE baseline values, and this one of the contributing factors to the total IgE in India is also a higher prevalence of helminth infections. And helminth infections like Ascaris lumbricoides can also cause tropomyosin cross reactivity, which can also cause false positive tests or reactivity with shellfish or cockroach or with your dust mites also. The other point that we need to know is that major allergens are not represented well in the aqueous extracts because they're already less in the fecal pellets and in the structure. So DERPI 23 are not represented. So those who are DERPI 23 positive, like in our data, 56% of the patients with severe asthma had DERPI 23 positive. And if we had done only aqueous extract testing, we would have probably missed a big chunk of patients who had a possible dust mite sensitization. And also, DERF1 concentration is hugely different between extracts. So they have found that a 14-fold difference is present when they compare DERF1 concentration between aqueous extracts, even among standardized allergens. So conventional extract testing alone does not give us a lot of information. We need to go beyond and look at how we can add components in house dust mite allergies. Now we need to understand that earlier, way back in I think in 2015-16, component testing in house dust mites was purely an academic purpose. We were just trying to understand what was going on, what is the different dust mites with prevalence, what are the different types of dust mites. Now we know that it is no longer an academic exercise. It is important to identify the specific components because we're able to distinguish major from minor components and able to direct not only avoidance therapies, but also dietary restrictions or even pest control restrictions or individualized therapies according to the distribution of dust mite sensitization. So we are able to not only look at the sensitization, we're able to identify severity, we're able to predict cross-reactivity and also predict responders to allergen immunotherapy. So how does it help us in establishing diagnosis? We know that dust mites, 80% of the population is nearly sensitized to DP and DF. And if you use DP and DF, sensitization is nearly 94% accuracy is present. But by adding DERPI1 and DERPI2 and DERPI 23 to the diagnosis, we have a slightly improved performance in the specificity, and DERPI2 has better performance in ruling out or ruling in a disease like specificity. And higher DERPI1 or higher DERPI2 correlates strongly with symptom severity and disease chronicity. We've already established that DERPI1 and DERPI2 not only confirms genuine sensitization, but the DERPI2 sensitized patients have a much more worse severe diseases. DERPI 23, again, in our data also and in Western data has been proven that it is a much major contributor to severe allergic rhinitis, conjunctivitis, and in asthma also. DERPI 10 will help us in identifying cross-reactivity, whether it is a cockroach cross-reactivity or whether there is a mite shellfish cross-reactivity. One important thing that we need to understand, we are detecting IgE to dust mite components. In the future, we should be getting the component IgG4, which actually becomes a marker of whether they have become tolerant to the dust mites also. And this is exactly where components is going to play a major role in the future. And I think we might see this come sometime soon. For somebody who's initiated on immunotherapy, whether they have developed tolerance or not, can be detected to individual components also over time. What is the clinical correlation of each? You can ask me, and I've already discussed this a little earlier. I'll tell you that although dust mite extracts have good sensitivity and specificity, there's not much difference between the your sensitivity of DERPI 1 to 10 or 23 combination versus dust mite extracts. But these patients have better significant association with type 2 biomarkers, especially elevation of pheno or eosinophils, and the same has been reproduced by understanding and combination testing with Blomia components. And also DERP23 individually on its own has a very high specificity and a strong correlation with pheno elevation in patients with asthma or allergic rhinitis. So the third point that we want to discuss about is allergen immunotherapy. And we know immunotherapy, we are aiming to cause desensitization as a shift from T to type 2 to T1, or reduce the reduction in the Th1 and Th2 reactive cells to a tolerogenic cells. We want to also increase the mute antibodies like IgG4 and IgA. And we know that sublingual immunotherapy targets the mucosal IgA and subcutaneous immunotherapy targets IgG4. But there are several therapeutic implications. What happens? We've also looked at, there is data that is actually suggestive of looking at the ratio of a dust mite extract like DP or a DF extract by the total IgE ratio of more than 15%. Okay, it predicts a allergen immunotherapy response. We can also find out if there is a DERP1 by total IgE ratio also, there is a more than 13.1% also predicts allergen immunotherapy response. These are all initial data. This is all coming in from China, and then some few data from Europe and US. But there is variability in, present. I think we might have better understanding as we look at how things go by in India also. The ratio may be a little different because we have a higher total IgE ratio in India. But this is something to think about. For somebody who has a normal or a lower range of total IgE, elevated but less than 1000, then this is important to look at DERP1 by total IgE may predict allergen response. It is also known that higher values of DERP1, DERP2, DERF2 actually have better immunotherapy response. The reason why we have poor response with DERF1 is because of the huge variation in the aqueous extracts content of DERF1, and also DERP23 content is also very poor in the aqueous extracts. So whenever somebody is already on immunotherapy, we can also find out if they are unexplained treatment failure. Somebody is on immunotherapy, symptoms are present, but they're not responding. You can use component result diagnosis to identify, are they really sensitized to the major components, or are they sensitized to the minor components, or are they sensitized to DERP23, which is not present in aqueous extracts, or is there a DERP10 strong sensitization, which is the reason why they are not responding to immunotherapy also is a potential use. We can also try to identify in polysensitized patients who have both dust mites, cockroach, pollen, fungus, and even shellfish. We can differentiate between primary sensitization versus secondary cross-reactivity. All this can be looked at. Importantly, in severe cases, in severe and uncontrolled asthma, we are able to use biologics, and therefore can we look at identifying dust mite sensitization and components to better predict which component to be added or which biologic to be added to therapy. For those patients who have multiple component positivity and a high total IgE, I think they are very good predictors of omalizumab response. Those patients who have an uncontrolled asthma, but those who don't have a major components may not respond well to allergen immunotherapy, but maybe better responders to biological agents. Those who have a high total serum specific IgE grades, like more than 17, more than 50, more than 100 values, are better responders to omalizumab initially, followed by immunotherapy to improve the safety and efficacy. And also DERP23 positivity, because of the high pheno, is also a better predictor of adding dupilumab to therapy prior to allergen immunotherapy in these patients. We also looked at in our patient data of 78 patients who underwent house dust mite immunotherapy, but sensitized by SPT or specific IgE with or without asthma, nearly equal distribution of SCIT or SLIT data. And we saw that DERP1 and 2 and 23 were quite high in these populations, but irrespective of the sensitization percentage, we had nearly 100%, 94.95% reduction in the total nasal symptom score by more than 30% at 12 months. So this was a significant finding that showed that maybe some depending on the allergen quality that you use also can determine that they, irrespective of their DERP23 sensitization, maybe there is a better responder to allergen immunotherapy. However, there was no significant difference in between the three different allergen sensitization, but we this is a very small data, may not be enough to replicate, but maybe a larger trial will help us in identifying what is the finding. We also notice that those patients who have a component grade of more than 5 grade, like more than 17, had reduced response compared to those who had a less than 5 grade. So basically, patients who had more higher values of dust mite components had a more significant local or systemic reactions, and therefore they had a reduce or a delay in the response, and those who had a smaller values actually responded better to immunotherapy. This is actually from a paper in allergy which looked at in the Mitra trial, where 12-SQ HDM sublingual immunotherapy was tried. There they studied whether DERP23 positive and DERP23 negative patients were selected. Please understand that in this data, DP or DF sensitization patients were selected. They did a subgroup analysis of DERP23 positive or negative. Irrespective of DERP23 status, patients responded well to therapy equally. So there was a significant improvement with the dust mite immunotherapy irrespective of DERP23 sensitization. And it also helps us in resolving cross-reactivity, especially when in India, we have not only high dust mite, 80% asthma on allergic rhinitis, we also have 70% patients with Blomia tropicalis sensitization. We also have a high Helminth load. So all these is what is called as a complex tropical phenotype. And there is a triad, and we need to understand how to look at can we identify which component is responsible for this patient's symptoms? And therefore, we can look at whether, depending on the shellfish consumption in coastal areas, we can do dust mite component testing to evaluate shellfish can be tolerated or not, or should they, is that the component responsible for reaction, or to also differentiate between Blomia. Why Blomia is because Blomia is also was initially labeled as a storage mite, but there is a high percentage of Blomia being reported in Indian households also. This also survives in warm and humid regions, and 60% relative humidity is necessary for it. And nearly 90% of asthma patients have prevalence with Blomia tropicalis sensitization. The problem is Blomia tropicalis, being a dust mite, has very poor cross reactivity between DERP and Blomia. There are several groups of studies which have shown that you treat only for DP and DF, Blomia also improves. But in India, when you look at this data right now, we don't have BLO-T5 testing as a single plex test, is only available as a multiplex testing. So as a BLO-T5 test not being available, we may not be able to tell very clearly what the true Blomia allergy sensitization is. But in our data, we found that nearly 15% of the patients were monosensitized to Blomia. Therefore, by differentiating between dust mite components and Blomia, we can identify, is there a co-sensitization due to duals, or is it dual sensitization? So where we can differentiate whether they need a Blomia immunotherapy or whether they need a combined allergen immunotherapy. So we now know that component testing can be used in several reasons, but there are several other situations where component testing is always not required when dealing with house dust mite allergy per se. This is because in patients where there is no treatment planned, like immunotherapy, intervention is not planned for mild cases. There's no need for testing for component, it's just added cost value. But if there is a clear clinical correlation between single extract positivity and symptom onset and presence, then there is no need for a component testing. We can go ahead with therapies. In patients who are already improving on immunotherapy, we need not do. But after immunotherapy and not responder, maybe there is a role for component testing. Those patients who are monosensitized without obvious clinical disease, in the absence of clinical disease and absence of clinical correlation, there is no need for component testing in such patients. Very young children, we need not do, because most often they're not, they're either DERP1 or DERP2 sensitized. These patients may not be starting on immunotherapy unless you're planning for immunotherapy off-label in less than 5 years of age group, then maybe you can consider dust mite sensitization. As I said, India's baseline Ig levels are quite high. So if you find somebody with a total Ig more than 2000, there is a possibility that there can be many false positive Ig values. So you should interpret these kind of situations with caution, and before proceeding with component testing, consider helminthic infections, consider other possibilities, and also then add your component testing to the settings. And in resource limited settings where the cost of component result diagnosis has to be considered, we have to look into it. And we need not repeat a component result diagnosis in the absence of clinical change. We can use it for monitoring, but then again, it is not yet recommended to monitor DERPI 1 levels or DERPI 2 levels before and after starting therapy. The better term in the future would be to look at IgG4 values. So component result diagnosis is a precision tool we need to use with precision, and it is not of academic interest. Do not routinely add to all SPTs that we need to do a component result diagnosis. Sir already gave a very beautiful flow chart from Pocket Guide 2024 Yaki Molecular Lagology book. Here in India, particularly being a subtropical and a tropical country, we do have a lot of blomia testing. So your SPT or a specific IG testing should include blomia testing in addition to house dust mite DP and DF testing. And if there is, depending on the positivity, you can decide whether they need a blomia therapy or whether they need a dust mite therapy. Or if there is all are positive, in such cases, you can resort to component result diagnosis. And then depending on which component is more dominant, we can take a positivity and take treatment. Important thing to consider is DERPI 10 sensitization is a poor predictor of allergen immunotherapy response. So no role of allergen immunotherapy in these cases. So overall, we begin with a good clinical assessment depending on the tropical history, the location, the food habits, the helminthic exposure risks, all have to be considered before even beginning your screening test. And you can screen with an SPT or a specific IgE testing, and then to proceed, you can go for component result diagnosis in complicated cases like polysensitized, etc., etc., etc. So after that, you rule out cross-reactivity, you look for co-sensitization, you look for primary sensitization, and then based on these findings, take a decision on the allergen immunotherapy product of choice. So in summary, India has a high dust mite burden. Blomia tropicalis is quite common, although there are regional variations. The classical history patient with a single allergen extract positive, you can directly proceed with allergen immunotherapy. But where CRD majorly plays a role is in the patients who are polysensitized, who are co-sensitized with multiple dust mites or with insects, or who have severe diseases, who have discordant findings with history, very small extract values and very high severe symptoms, because the DERPI 23 may be something that is playing in these cases. High total IgE values, helminthic infections are suspected, history of shellfish reactions are definitely should undergo component result diagnosis. Allergen immunotherapy, you decide based on the allergen, based on the major antigen and the clinical history, and then go by the treatment. Predictors of response, we can use ratios like specific IgE by total IgE or component by total IgE ratios of 13 and 15 respectively. We can use, especially non-responder to immunotherapy, use components to reconfirm the diagnosis. So CRD is a precision tool. It is for personalized therapy and not for general use. So I thank you again for the attention and for the opportunity.
Thank you so much, Dr. Karthik. As Dr. Neera rightly said, it's a masterpiece. I mean, we could get a lot of insights and the studies that had been done on HDM. Now, moving on to the very interesting panel discussion that we are going to have. And I would like to call upon Dr. Saundarya. She is a pediatric allergist, a practicing pediatric allergist, very senior ma'am. And over to you, Dr. Saundarya, for the panel discussion.
Thank you, madam. So with such a wonderful panel, I'm sure that we'll be incorporating all the three topics together in a clinical case-based discussion. So without further ado, let us start. Today, we'll be discussing the panel on the various clinical facets of house dust mite allergy and how to use component resolved diagnostics in coming to a conclusion in each case. So let's begin case 1. Here we had an 11-year-old child who presents with recurrent sneezing and coughing at nights, including the early mornings all year round. He also has exercise-induced wheeze during sports. He has a personal history of atopic dermatitis in childhood and a family history of allergic rhinitis. On examination, this bilateral nasal turbinate hypertrophy and expiratory wheeze. Pulmonary function tests show a reversible obstructive pattern with the post-bronchodilator FEV1 showing the classical improvement. His initial diagnostic workups, standard tests were performed. SPT showed positivity to dermatophagoid teranus and dermatophagoid farinae with a wheel more than 10 millimeter. His serum total IgA was done, which was 320. A routine specific IgA to serum HDM extract was done, which was also high at 15 kilonewtons per liter. So, Dr. Krishna Mohan, this question to you. What do you think will be the routine next pharmacological measures that we would imply for this child with this workup?
Okay, thank you. So, as you have told in the history, this is probably a case of allergic rhinitis with asthma, with all the features of progressing atopic march. It started with allergic rhinitis, atopic dermatitis already there. He is getting wheeze and he is having night symptoms. His PFT is also deranged. So, probably is a case of allergic rhinitis, it's asthma and atopic dermatitis. So, if we follow the GINA guidelines, first and foremost, we have to do everything for that allergen avoidance measures and all. So if you are follow the GINA guidelines, we know this age group is in between 6 to 11 years. So he has to be placed in the step 3. So for the preventer or controller, we need to start this MART. That is one option at this stage. We can use the formoterol budesonide combination. And along with that, as the reliever, we can advise him the same as the reliever. And also we can give him the intranasal steroid for his allergic rhinitis component and the management of the atopic dermatitis also. Further things we have to decide based upon the further history.
Thank you, sir. Absolutely. The child was started on mometasone nasal spray and MART as sir described. Now, over the next 6 months, this child showed a fair response. However, was never completely symptom-free. Partial control was there despite testing good compliance and good technique. The dosing of this MART and INS could not be tapered and he regularly needed rescue doses. So, Dr. Saibal, what do you think will be the next step in management and is this a right candidate for immunotherapy? Saibal, sir.
Yeah, thank you, Dr. Soundarya. You have rightly said, and as Dr. Krishnamona just stated, because initially when we have diagnosed this child having allergic rhinitis with an allergic asthma, and there is a sensitization to the house dust mites, both the DF and DP. So the child is usually started with the pharmacotherapy and the environmental control. Now, when we are means following up this child, and we are seeing that the MART or the INS could not be tapered down, rescue doses are still needed. That means we are not achieving the complete control of the disease. Now, what it is which is preventing this child to have a complete control? It is very well it is saying that is a dust mite, which is the allergy if we call it now. So this, what it causes, it not only causes the initiation of the disease, but it also maintains the disease and causes the progression of the disease. So in spite of using the anti-inflammatory therapy, the minimal airway inflammation, both the upper and the lower airways, is maintained, and that is maintained because of the dust mite allergy. So the next step in the management would definitely to consider that whether we should take up this child for an allergen immunotherapy in conjunction with the allergen avoidance and the pharmacotherapy. And I think that this child is the right candidate for the immunotherapy.
Thank you, sir. Yes. So based on his age, because he was below 12, the parents were given a choice regarding the skit and the slit drops for the house dust mite. They had chosen the slit drops and the child was put on the HDM slit for 1 year. However, at the end of this year, the child still had partial control only, not much improvement and needed rescue meds along with the maintenance. So Dr. Karthik, can you just highlight, now we are at this crossroad. How do we further proceed in evaluating this child?
Right. So already uncontrolled asthma with allergic rhinitis, definitely house dust mite sensitization is there. There is no clear, I mean, there is no doubt about the inciting agent. In addition to all the other lifestyle measures and pharmacotherapy measures and everything, here I would definitely want to look at other than before I proceed with therapy also, now that we have some data which also helps us in, although I said that you should if there is a straightforward sensitization anything, but this patient has a severe asthma or an uncontrolled asthma, I would want to address those points first. Look at that asthma optimization, step 4 or step 5 therapy. Maybe consider even now that we have omalizumab anti-IgE therapies for achieving asthma control would be something that I would still consider in this case. But at the same time, I have to look at, am I able to also achieve disease modifying therapies down the lane? So is disease modifying therapy useful or not? In a severe patient with dust mite allergies, I would consider doing a component resolved diagnosis, and also start looking at a possibility of adding maybe looking at biological therapies also simultaneously to start looking at most of in this patient.
Thank you, Dr. Karthik. Thank you. Yes, here we should consider adding biologicals as well as evaluating simultaneously as to how much further we can titrate and personalize medicines for this child. So as sir has said, now we have done the CRD and these are the results. The DERPI 1 8, DERPI 2 15, all positive. The F1 was also 8, again high positive. The F2 3, DERPI 5 6, DERPI 7 7, DERPI 23 9, DERPI 10 was 12, all kilounits per liter, all of it significantly positive. So Dr. Krishna Mohan, how do we interpret these results? Now we have so many positivity. How do we interpret these results?
So, as you said, DERPI 1 is strongly positive, so it is a major HDM allergen. It is indicative of a true sensitization. DERPI 2 also, it is more positive, 15. So it is a very strong HDM sensitization. Similarly, F1 and F2 is also positive. It confirms the sensitization to both the mite species, that is the Farini as well as the Taronicinus. And even P5 is positive. It's a mid-tier allergen associated with asthma severity. And 23, as Dr. Karthik mentioned, with very much importance, it is an important marker of a clinically relevant HDM sensitivity and asthma and rhinitis. So all the major allergens, P1, P2, as well as 23 is positive. P10 is also positive. That may be probably due to a cross reactivity. So as all other major allergens as possible, we can consider as a very genuine, strong HDM sensitization.
Thank you, Dr. Krishnamohan. Yes, as sir has stated, yes, all the clinical components are very significant and all these are predictors for the future. So, Saibal sir, will this child now be a candidate for the split tab SensiMune, which is now available and licensed for use in our country? Will he be a candidate for that slit tab still? Now he's 12 years old. We have gone 1 year with slit drops. Now he's above 12. So can we use the HDM slit tab now?
Yeah. Thank you to Dr. Soundarya. So that means like this child at 11 years of age, when the child's symptoms were not adequately controlled, or the child was not able to be stepped down despite having the optimum pharmacotherapy, and we also maybe there must be some environmental control, the child was initiated on AIT. Am I right? Okay.
Yes.
So now we have 1 year down the lane, but still we haven't achieved that the adequate symptom control or maybe the complete control of the disease, or maybe tapering down of the medications. Now the IACI has given the early stopping rules and the late stopping rules for the allergen immunotherapy. Early stopping rules is when we look into the stopping of the allergen immunotherapy at 1 year of maintenance dosing. Okay. Late stopping rules is at 3 years or 3 years of the maintenance and dosing. So if we take that, says this child initially was put on the immunotherapy, and if this child was started on the subcutaneous immunotherapy, because of the age, we can only start the kit. So it usually requires by the conventional regime to have at least 3 to 4 months of the build-up phase. So that means the four months, that means only 8 months into the maintenance dosing, we are evaluating the child for whether we are achieving the control. So usually the thing is that we usually have to wait for early stopping rules at least 1 year of the maintenance dosing. But even if we say at this stage, we are finding that the child is majorly having the class 1 and the class 2 allergens, which is positive, the WP1, WP2, TARIF1, and TARIF2. So this is the child is a good candidate for the AIT. But there's another important point is that WP23 is also quite high. And though it has been traditionally, it has been said that if a patient is showing quite significant positivity to the WP23, the response to a particular allergen immunotherapy, which is usually the low in the WP23, may not be optimum, it will be suboptimum. But we have seen in the Mitra trial, though the subgroup analysis, I think we have just seen in the slide by Dr. Karthik, though the subgroup analysis, even those patients who had a significant WP23 positive, they still had an optimum control or optimum control of the disease by the sublingual 12-SQ HDM slit tablets. So, well, I think that since this child has attained the 12 years of age, so, well, it means this child can be put on the slit tablet, which is available in our country. There's another very interesting twist into it. Now, the twist is that we all talk of the skit completing the skit, the slit completing the slit. But how much we talk of the skit getting crossed over to slit, the slit getting crossed over to skit, and what is the outcome of that? There has been few good studies which have shown there's the crossover from the skit to the slit in the maintenance phase, at least around 1 year in the maintenance phase, it has almost equal efficacy as that of the entire being of the one form of the immunotherapy. So in this case, though we haven't achieved the 1 year of maintenance and stopping rule, there's still 6 months to go. And maybe we'll have to wait for another, I said it is 8 and another 4 months, the child can be shifted to the slit. And then we can evaluate the child for another four months and then see how the child is doing.
Thank you, Dr. Simon. It's very nice, really a point to learn that there are crossover studies and they have had a very good response equally as well. Thank you, sir. My next question is, in the light of these reports, the mother wishes to know the long-term outcome of a child. So, Dr. Karthik, how will you talk to this mother regarding the long-term outcome of a child? How will you counsel her?
So, I mean, that's the billion-dollar question. Everybody wants to know, even before starting treatment, even before asking long-term outcome, I think the first question they'll ask is, will my child be cured? I think that's the first question that they ask. And then that I think we address the question from there only, and that has already been addressed during the sublingual immunotherapy that was started earlier. So when we talk about including in a patient who has not responded, partially responded to the sublingual immunotherapy in for nearly 8 to 9 months now, and then now there's an option of changing treatment. We talk about outcomes on several points. The first thing we look up is is immunotherapy really indicated, and is there any predictor of response to immunotherapy in these patients? Does Mite sensitization, good correlated clinical history, allergic rhinitis, house dust mite driven allergic rhinitis and asthma are all very good predictors of immunotherapy response. We also start looking at, can we look at some numbers? Can we look at that's where the dust mite DP by total IG ratio, or a DERP1 or a DERP2 by total IG ratio sometimes comes into play. But I think if I go back and see, I think that it's somewhere around 8 or 9 divided by total IG was 320 or something in this. So
yes.
the ratio may not be satisfying the values, but then smaller dust mite values like less than 20, 30 actually have good response in allergen immunotherapy. So irrespective of all this, the clinical presentation, how the child has responded to initial treatment and pharmacotherapy control, then sublingual immunotherapy also, which product contains what major component or not, the constitution of each immunotherapy product also makes a difference. So this child is not only sensitized to one and DERPI 1 and DERPI 2, but also to DERPI 23 in that number. So I mean, like, we have data that has shown that irrespective of the sensitization, we can start a standardized form of immunotherapy with a good quality and a good content of major allergens will have better outcomes. So, and something that I also see in my practice, this is probably not greatly reflected in data. This is more of a practical thing, is that the more they develop if they start developing any local reactions to immunotherapy, that indicates that they are getting immunostimulated by that immunotherapy. So in the absence of local reactions, I would start wondering, is there enough content in that allergen or an extract to stimulate the immune system. So more often than not, the standardized forms of immunotherapy have some minor local reactions, and that also can predict whether they are ideally suited, and therefore the overcoming this local reaction itself is a predictor of tolerance development. So all these I will look at when I say that what is the long-term outcome, and then I will probably say, like how sir said, 6-month and 12-month early stoppage and late stoppage data. I'll probably look into them also later.
Thank you, Dr. Karthik. Thank you so much. Now, another question to you, just for the clinical discussion. Suppose this child's results showed this way, where the major allergens of DERPI 1, 2 and DERF 1, 2 were not so positive, and DERPI 5 and 7 were also not so positive, but this was isolated DERPI 23 positive. Then how would you interpret these results? Suppose this child's CRD had shown like this.
So, I mean, unless the parents are really educated, they won't be asking any questions here. But then for us, it is a little challenging. What we start thinking is there a DERPI 23 content in the therapy that's available? What we know is the aqueous extracts that's available, at least in several markets, even in European markets also, they have very poor DERPI 23 content. But recent papers have shown that there is nearly 25% of the DERPI 1 dose is present in DERPI 23 is 25% of the DERPI 1 dose. So let us say it's 7.5 milligrams, 25% of that dose is present in the sublingual immunotherapy tablets available. And they have also shown in these studies that this DERPI 23, because it is highly potent, it can still stimulate the mast cell and it can still stimulate immunotolerance, and IgG4 development has also been documented. So even if they're isolated DERPI 23 positive, I think if you use standardized forms of immunotherapy, particularly the product that's available in India, I think that is a very good tool to still use in these patients. And I have also seen personally in my patients who are isolated DERPI 23 who are doing really well on the 12-SQ HTM.
Thank you, Dr. Karthik. I think you have answered the next two questions itself. So how would the child's management differ? Will the HDM slit tab be useful? And how does this help in directing different treatment plans? I think with that previous slide, you've covered these two. So I will just go further in the interest of time itself and just summarize in this case, the importance of CRD in an HDM asthma or AR case. This does confirm house dust mite as a primary driver of disease and distinguishes genuine allergy from the bystander, the cross-reactive like the DERPI 10. It helps in risk stratification and severity prediction. High IgE to DERPI 2 and DERPI 23 are associated with severe allergies, rhinitis, and asthma with higher risk of exacerbation. It helps us guide allergen immunotherapy, like our panelists have said. It helps us select patients and identify those who are sensitized to major components and rule out those who are only cross-reactive sensitive. It helps to monitor therapy over time. This also Dr. Karthik has touched upon. So what are the ERK guidelines on HDM allergy? I'll just go over this quick and then we'll go to the next case. So first we diagnose the symptoms, the atopic status, do the CRD, identify comorbidities, characterize the allergen phenotype, then proceed with the provocation testing, evaluate the impact of allergen sensitization on the asthma symptoms and control. And if we have asthma with HDM sensitization, we proceed for regular control of treatment. And if it's a HDM-driven allergic asthma, we consider adding HDM AIT to the regular controller treatment. So with that, let's move on to case 2. Here we have a 1-year-old child who has history of eczematic skin rash over the body since the last 9 to 10 months with intense itching more at night. She has been given multiple moisturizers, steroids, and emollient creams, however, poor response. A dietary chart was maintained to search for food allergies, but no specific food association noted. Examination showed this extensive atopy. Anthropometry normal for 8, systems were normal. Her investigation showed a moderately high total IG with 1500. A specific IG profile showed mild positive to milk and egg. A house dust mite was very significantly positive at 45. Aspergillus negative. Cockroach and shrimp also showed mild positivity. Her skin prick test could not be done because of extensive eczema. Now the parents are concerned because they are pure vegetarians. How the shrimp is positive in this report. So Dr. Saibal, can you tell how the shrimp turned out to be positive in this child born to a vegetarian family?
I think we already had shown
Yes, yes.
actually seen this in Karthik's slide and
Yes, I think.
So these are the cross-reactive tropomyosins, which is there. So in these three groups. So usually because of this cross-reactive tropomyosins, it shows positive to the shrimp.
So I think your slide and Dr. Karthik's slide both, and this is a complete summary of both.
Yeah.
Now, in this child, a CRD was performed, and the CRD showed negative to most, except for a significant positive to DERP10 and DERP11. Dr. Krishna Mohan, how would we interpret these CRD results?
So here, as you can see, DERP1 only is mildly positive. Other P2, F2 is negative, but P10 and P11 are positive. So as we discussed and as Dr. Karthik mentioned, this can be some cross reactivity, and that may be the reason for that. P10 and P11.
Yes, sir. And so this, yes, Saibal, so tell me.
Yeah, and but we have an interesting component over here. That is the paramyosins. That is the DERP11.
11.
So now
Yes.
the DERP11 has come up in recent years to be one of the driver of the HD associated atopic dermatitis. And why it has come up as an important driver for the HD atopic dermatitis is also quite interesting. Because so far we always knew that atopic dermatitis is basically because this important component is the skin barrier defect because of maybe the filaggrin mutations. And along with that, the importance of the staphylococcal antigens, which is also there, which is important in the pathogenesis of the disease. But this new interesting molecular component, that is the DERP11. So DERP11 positivity, which is a paramyosin, it causes a significant epitheliitis and also a significant dermal keratinocyte activation by a unique pathway, which is only activating through the TLR receptors. It can cause activation and inflammatory cytokines in the milieu, most of the alarmins, IL-25, 23, and the TSLP, and which, along with the cephalococcal antigens, acts as a super antigen and causes extensive stimulation of the T cell receptors, which does not need it at times it does not need even the antigens itself because they get activated. So this is coming in a big way as one of the drivers of the atopic dermatitis with house dust mite driven. And so in now recent guidelines, we find that there's a very niche area of the HDM AIT given to very few selected of these patients with DERP11. But so this is one thing which we need to reckon in this report.
Thank you, Dr. Saibal. So this was just to bring out what we wanted to show in this case. That's a true and the cross-reactive allergen. As Sir said, the true allergen is the primary allergen which causes the sensitization, and the cross-reactive one is the one who piggybacks and elicits the response. So distinguishing between true and cross-reactive allergen, the initiation of the development of IG during sensitization phase is the true allergen. It also binds the pre-existing IG and produces clinical symptoms. A cross-reactive allergen cannot initiate the formation of the IG upfront. So there's no sensitization phase. However, it piggybacks and binds to the pre-existing IG, can produce clinical symptoms, however, variably. So, Dr. Karthik, the parents again wish to know, will this child outgrow her atopic dermatitis as she grows older? What would your thoughts be on that?
So, yes, there is a very good chance of, I mean, generally the norm is that atopic dermatitis usually gets better as somebody gets older. There are going to be some features which delay the remission in such patients in such situations, because dust mite exposure, because there is DERP1 and DERF1 also positive in this report. 1 point something report
Yes,
also
yes,
is there.
yes.
And so this kind of a atopic dermatitis, if you also ask generally, is not only an IG mediated, is a non-IG mediated, is also combination is there. And there is the good thing about this condition is there is a very good ability to overcome or overgrow this atopic status as they grow older, in as a natural history per se. Some part of them will develop an atopic march, and that will be determined whether they are sensitized to aeroallergens at an early age or not. Looking at the DERP1 and DERF1 values in this patient, I might say that yes, the atopic dermatitis may get better as they age if you take adequate precautions like dust mite proof covers also to be added to reduce the contact sensitization in such cases, and good treatment topical therapies if you use, you will overgrow. But watch for a possible in the future you may develop an atopic march like allergic rhinitis is possible maybe a few years down the lane. I mean, I
Thank you,
think you're
Dr.
asking
Karthik.
about DERPI 10 and 11. Sir has already explained very
Yes,
clearly.
yes.
I think I will say, I will blame it on this and then say this is why the shrimp is positive and then close the
Doctor, with that, yes. I
A
just wanted to
small,
know, Doctor, tell me,
small,
Saibal, tell me.
a small thing that there's a recent this evidence which is coming up. This is regarding this paramyosins. That is a WP11. See, paramyosins are quite ubiquitous proteins. They're present all over. So now there's a way is coming that those who are paramyosin positives, in the case of atopic dermatitis, the chances of outgrowing the dermatitis becomes less. So there's the role of that AIT. Yeah.
Also, one more thing, sir, is that DERP 7 also. In this patient, there was no report, but then I think DERP 7 is also something
Okay.
that's been strongly associated with persistent forms of atopic dermatitis, especially in the younger age.
Yes, WP7. But what happens is that becomes somewhat a like bystander of that molecule. But this becomes both a driver molecule for the disease, along with the other non-IgE mediated mechanisms, the filaggrin, maybe irritations, and staphylococcal infections, and all those things.
Saibal sir and Karthik, I'm having very less experience of AAT with atopic dermatitis. So one doubt is that suppose you are getting only DERP10 and DERP11 positive without positivity of DERP1, 2, F1 and F2, then will you start immunotherapy?
Let me tell you my experience, okay? Then I
Yes.
would like to know the experience of Karthik. See, atopic dermatitis is a very frustrating disease, okay? And we don't have dupilumab in our country. Okay, even if we get the dupilumab, majority of our patients would be able to afford that. So that's important. So basically, it is all the moisturizing the skin, the steroids, the wet wrap therapy, or the this UVB phototherapy, short band UVB phototherapy, and to certain extent the tofacitinib and all those drugs which is there. But even we have seen that with all this, the child suffers a lot. So what I have seen, like it, I'll say that for my experience for the past one year. So the child in whom I've said DUP11 is positive, and the child has been put on the HDM-AIT, this child has improved over a period of time. Though my experience is not very large, so it is from a small body of the children, maybe like here, around 30 children are on the immunotherapy. They're into the maintenance phase, and they're really showing the improvement in the actually the use of the need of the steroids, and also the skin is getting better. So I am quite very much hopeful about the HGMAIT in this only particular subset of the patients of the AD who has a DUP11. And as Dr. Karthik was saying, we don't get the DUP7 and always, but in few of the reports, like we get DUP7. So in that, DUP11 positivity has helped to recognize this as a child. There's a small window opportunity of the AIT giving to these children. And it's really helping them. It's helped them. And especially in our country, we are actually, in a way, to a certain extent, we are good responders to the AIT. And well, that is a totally different discussion altogether. I'm not going into drive into that. But anyway, we are, in a way, good responders to the AIT in the terms of the patient is properly selected and allergen is of good quality. We respond quite well.
So yeah, atopic dermatitis, again, like sir said, echoing your points only, sir. But again, numbers are very small patients because we choose very carefully, and most often than not, immunotherapy is added as a out of lack of options like dupilumab and other therapies. And these patients are given atopic allergen immunotherapy to dust mites, even with standardized allergen immunotherapy have been given. And irrespective of what their molecular sensitization has been there, what I've seen is only 50% of them have some improvement. And the difference I've noted is the age at which we start the immunotherapy. Less than 10 versus more than 10 has been a small cutoff that I've used and probably seen in my very small data experience, at least. Probably adding a little bit more of the previous experiences at our center here. The patients who are younger and who have lesser dust mite components positive, they tend to have lesser number of dust mite component positive. I'm talking about DERPI1, DERPI2, plus or minus any other allergen. Let us say less than 5, less than 10. The more the number of allergens keep getting positive, the lesser the response rate. The more the molecular spreading has already occurred, the lesser the response rate has been noted also. These patients also in our experience, the ones who have responded are the ones who have coexisting rhinitis. I think if there has not been much of a coexisting rhinitis in these patients, their response rates have also been on the lower side. So irrespective of the molecular data, I think if you ask me, I would say that the lesser number of molecules positivity and yeah, age at which immunotherapy started has some say, but we don't have yet. It's only given out of a patient benefit.
Absolutely right, Karthik. Because when you talk of atopic dermatitis, for the age, we divide into two main phenotypes: adult onset atopic dermatitis or childhood onset atopic dermatitis. It's basically the childhood onset atopic dermatitis, or to be more precise, infantile onset atopic dermatitis, who show more DOP11 positivity, and they are the candidate who are more responsive to the HDMA, not the adult onset atopic dermatitis. They usually are not the candidate.
Thank you, sir. That was so interesting. Just to summarize the importance of CRD in this child with atopic dermatitis, CRD to DERP11 can flag the HDM atopic dermatitis phenotype within the broader HDM allergy population. This sensitization of DERP11 is linked to a more severe, persistent, and often early onset atopic dermatitis, so it is very useful. And knowing that he has genuine IgE to DERP11 and not just to his cross-reactive components can dictate and guide the HDM allergen immunotherapy, as well as a good avoidance, as well as monitor response as a part of precision medicine-based atopic dermatitis care. Moving to case 3. Here we have a 10-year-old child who presents with history of recurrent facial swelling, abdominal pain, vomiting, and shortness of breath each time upon eating roti, chapati, even upmas, and since the last 7 months. He is, however, able to eat whole wheat bread and bun from outside. No history of exercise after meals. There's a history of childhood wheeze. He has needed the budesonide MDI for the last year, and he also has mild persistent allergic rhinitis. In the family, no such food allergies were noted. Mother and sister have asthma and are well controlled on MDI. Examination findings: child was stable, weight is little less at the 10th centile, otherwise height was normal. Features of allergic rhinitis with a mild expiratory wheeze on respiratory system examination. So on investigations, the SPT to wheat was negative because that was the primary worry. CAT came positive, HDM was strongly positive. Other foods negative, including rice, milk, and peanut. Cockroach and aspergillus also negative. Specific IG also to wheat negative. The house dust mite only was significantly positive at 56, and the rest were negative. So, Dr. Saibal, what is your interpretation of these results in this child who seems to have a seemingly food allergy kind of presentation?
Yeah. Thank you, Dr. Sosandel. This is very interesting. See, always when we say that history, we'll just say, well, okay, yeah, this child has some kind of the food allergies, and we say the jump down to maybe some kind of wheat-related allergies. But as we know that the rule of thumb is that when we have to diagnose a food allergy, first thing it has to be a temporality, that is having the food and then having the symptoms, and then the consistency, that is each time from the index reaction. After that, each time the child or the patient has that, the patient should have the reactions. So this too is very important, that is the consistency, temporality, and to some extent now the people say that how it is the evolution of the disease. But here we are seeing that if you're talking about the wheat, the child is having when they sweet from the outside, they are not getting the symptoms. But when they're having the thing from cooked from home, they are actually getting the reactions. Okay. So means this is how we try to detect that. Okay, we are thinking that well, the child is having some wheat based diet, having the symptoms, abdominal symptoms, and also the facial swellings, and there is also some little bit of the the respiratory symptoms. So then what component? Because nowadays, when we know that the storage mites, which are actually, they grows inside these barns, so having the rice, having the wheat, mainly the wheat where we stored, and they are actually an important cause of the allergy, not the sensation, but the allergy. So and here we are, it has been tested. So it has shown a house dust mite positivity to the specific IG, that is the whole allergen extract, and also the skin prick test for positivity. So here it comes the thought that, well, this could be related to the storage mites. So it could be related to the storage mite disease. We have some exotic names of this, the Van Gogh syndromes and all. So, but how do we confirm it? Confirmation in this case, it demands a component testing, because, and the component should include the storage mites as well. That is the Chiro, that is the leptoglyphus and the tetraglyphus, and all these storage mites has to be included into the component. And though we do not have right now, or the only the mite panels, else like the singleplex testing, but maybe in very short time we'll be having the mite panels, which will only include the house dust mite and the storage mites. So that's how the way to go.
Thank you, sir. Dr. Krishna Mohan, would you be able to tell what is the diagnosis? Sir said some fancy name. So what diagnosis would you say?
Yeah, so sir, I didn't tell the name. name.
Yes,
So it
sir,
is.
did tell the name.
So it is. It is probably an anaphylaxis to that storage mite. This
Storage
thing. It
mite.
is the fancy name is pancake syndrome. It is a oral mite anaphylaxis. So as sir said, a CRD will help in
Confirm.
find. Yeah.
Thank you, Dr. Krishnamohan. So the CRD report came like this, where the wheat omega-5 gliadin was negative, and even the lipid transfer protein was negative. The flour mite whole extract showed 9.204, which was positive. Even the tropomyosin was showed 5.603 positive. The P10 also positive. The peanut was negative. So, Dr. Karthik, how would you interpret this report? How does this report shed light on this case?
Before I just answer, I would definitely want to say that when we look at a scenario where there is such a case coming up, our choice of allergen while testing also makes a big difference. testing house dust mite HDM usually in India is DP or DF, and sometimes we tend to ignore the storage mites from getting tested. So one of the first things we need to look at is from the history and the patient's locality. What do they have in their home? Do they have a granary or some storage capacity in their home? Generally, you should also start adding storage mites in testing for such patients. Uh, so maybe if a storage mite and allergen was done at SPT, it would have sorted out, given of a little bit of a diagnostic clarity there also. Second thing is I really appreciate that you've done TRIA 19 and TRIA 14 despite wheat is negative, which means yes, that does occur sometimes. Wheat whole extract can be negative and still the component omega-5 gliadin and LTP can be present, and this can explain sometimes wheat induced episodes in certain times and not there and other times also. So it's a good thing to always rule it out as a rule. Acaricyro is the predominant storage mite, and this has been reported more among the sub-Himalayan area where Chandigarh, Himachal Pradesh to Bihar, until that entire rice cultivation storage household phenomenon. There are a lot of Acaricyro and lepidoglyphus being reported in this belt, and there is plenty of such patients with unexplained anaphylaxis being looked at. Maybe one of the cases is this. And in this scenario, there is two possibility. One is the tropomycin the cause of the reaction, or is the Acaricyro like any other ACA S1 or S2, is that the cause of the reaction, is something that needs to be looked at. If I'm not wrong, we have the multiplex testing, which has an Acaricyro. No,
Yes,
it has only
yeah.
LebD2 and
LebD2 and
yes. So in this, I would attribute the reaction probably to both a tropomycin possibility or to the dust mite in this. And I would just say that they need to start maybe change their storage, how they store the food, and probably change the packed foods, maybe packed atta maybe for some time, and then start maybe a potential for allergen immunotherapy, because there is also rhinitis in this patient down the lane.
one thing that is usually we see that, because see, this is quite common in the eastern part of the country as well. So one thing which is usually we tell to the relatives is that what you do, you just spread the entire wheat under the sun, okay, and just keep it under the sun, and then restore it into a new in a totally a new container. So what happens is that is under the sun in a dry day. So what happens with a very low of the humidity, it gets killed, and all the storage mites gets killed in 1 to 2 hours, because all these mites, they cannot drink water. They have to absorb the water from the outside. So as the relative humidity goes below 40%, they all dies up in the 1 to 2 hours time, and that to under the sun. So, and then if they change it, and they usually do not get the symptoms. So that is usually since it has been done.
Thank you, sir. Dr. Krishnamohan, now with the diagnosis and the risk level with a floor sample showing the Acaricyro infestation, what will be the next step in management regarding this child?
Yeah, Dr. Karthik has already told regarding that. First and foremost, we have to counsel the patients and parents regarding that. There is no need to unnecessarily avoid the wheat, because wheat is not the villain here. So they have to avoid the improperly stored flour. They have to follow the airtight storage and all those things. And if as the skin prick test and the immunocap has been found to be positive to the house dust mite, we can start immunotherapy against the storage mites. And he can definitely resume a normal diet with fresh ingredients.
And maybe drying out that, like sir said, I have not found that anywhere. I found it only when sir said. Yes.
The one problem would be that even the dead particles will still have proteins capable
But
of.
the interesting part of the Kairos zero is that, see, the severity index scale Kairos zero is not TRI 19 or the RH2. So what does that mean? That means that the positivity to the clinical reaction, that is not as high as the RH2. So what happens is that, as you rightly say, that the dead particles would still be there, but once they dies off and there is a reduction in, so it has been shown to work. So that is one of the poor man's and advice which we give to the people who are mostly they're coming from the rural areas and the suburban areas. So that usually works because we do not have immunotherapy for the storage mites in the country as of now. But that definitely means removing the entire flower and asking them to get another. So that is one of the ways. So this is there.
Thank you, sir. Thank you. So just to summarize in this case, what is the importance of the component resolved diagnostic? It distinguishes the true triggers, identifies like how in this child the specific IG to a flammate component with like acaricide or tropomycin, and hence a child who has suspected wheat allergy and this misdiagnosis is prevented. It rules out cross reactivity, just like how the genuine mite sensitization of the floor from the cross reactivity with dust mites or pollen. So the symptoms recur only with stored and infested foods. It helps to predict a clinical risk and correlate with the anaphylactic potential. It helps guide targeted avoidance and mite specific measures like freezing or like such and drying the flour and most importantly avoiding unnecessary wheat elimination. Prognostic monitoring is improved, and this serial tracking shows that there's a declining levels once immunotherapy is started. Coming to case 4, here we have a 9-year-old child who presented with recurrent history of pain abdomen, some sort of tiredness and easy fatigability. There was pica, history of worms were seen in the perianal area at night occasionally. History of occasional upper respiratory infection, one episode of wheeze noted in the last year. On examination, child is stable. Anthropometry showed the child being underweight for age. There was pallor. Systems were normal. Investigation showed anemia with hemoglobin 8.6. Total count platelet normal. Differentials near normal. A borderline high eosinophils, otherwise normal. Total IG moderately high, 1400. SPT here was positive for house dust mite, where the rest were negative. So in the light of this child having wheeze, slight rhinitis, high IG with a HDM positive SPT, component resolved diagnostics was already done. And these were the reports where DERP12, DERF12 negative, DERP10 positive, DERP23 negative. So how can we interpret these results, Saibal sir, in this child?
Okay, again, we just I'll be as brief as possible. We know that the mite helmet cross reactivity, which is quite common, and in terms of the tropical context, it's there. So this child, we can very well understand that looking into the entire clinical scenario, and the eosinophils are high, the IG is high, the pica is there. So the helmet infestation is quite high. It's very likely to in this child with the ascaris and all. Child is anemic also. So, and this topomyosin again being the link that is the DAPI10 is positive, which is a cross reactive to the helminth and tropomyosin, and so this is just showing a cross reactive component which is positive because of the helminth infestation.
Thank you, sir. So when all these allergens are negative, just I want Dr. Karthik to just tell me the significance of DERP10 positivity in this child. Just I know it'll be almost repeating what Dr. Saibal said, but I want to ask further. Once you answer this, I'll ask further. Dr. Karthik, you have to unmute.
So we are looking at definitely some form of a cross reactivity, and cross reactivity informs all the 3 pan allergens have to be looked at. DERP10 and DERP20 also, arginine kinase, and also possibility of even your paramomycins. But in most often than not in India, helminthic infections are almost always associated with a DERP10 cross reactivity, and this is an extremely common scenario. A lot of high IG levels are present in these patients, and they get false positive responses, and that is causing some of the unusual reactions in such patients. In there is a difference in how we get infested with worms, and also with regions also. Certain freshwater areas, especially in certain parts where anisakis worm has also been proven, that worm infestation of a fish, and then you consume the fish, and that fish causes you tropomyosin-like reaction. So this also needs to be looked at when you look at data. You should ask them, do you have history of shellfish reactions? And I would definitely strongly label this DERP10 positivity in this patient as secondary to a helminthic infection, and target helminthic therapies in these patients rather than looking at other treatment options down the line.
Thank you, Dr. Karthik. Dr. Krishna Mohan, the last question of this panel to you.
Can
What
I
is
add
the
a small
management? Tell me, sir.
So the small thing, okay, I just
Tell me,
want to
sir. Tell me.
do a little bit interesting thing. See, like the timing of the helminth infestation is very important. Say a child in India, born in India, okay, who has this kind of the scenario, and say a child born in US is coming to India and getting an helminth infestation and just showing this tropomyosin positivity, do they behave the same way or the different way? Interestingly, both of them behave in a different way. In a different way because it is the age at which the helminth infestation occurs, number one. And the number two, it is the environmental context in which it occurs. So usually in Indians, we say that early age of infestation and with a very high load of the this various environmental endotoxin load, which is very, very high. So there is a Th1 driven disease. And usually in this case, there's more of the IgA productions, and which causes symbiotic relationship and keeps the allergy at a bay. But if a Western born child is coming into India and gets a helminth infestation, so there usually the child gets a very vigorous Th2 response. And in them, even this cross reactive DERP10, we always think that the cross reactive is always, it is clinically silent, but it's not. But it's a context in which the cross reactivity is being achieved is important. They can get a serious reaction for that. That's the one point I just wanted to bring into this.
Thank you, sir. Thank you so much. I was going to ask, that was my other question, which I had kept, that I will ask. You have answered this before. Dr. Krishnamohan, can you just throw light on what is the management in children with such symptoms
I
and
think
such
uh,
efforts?
I think Dr. Karthik has already answered. So it is not basically allergy, this patient. Just because you are trained in allergy, you need not give allergy medications to all of the patients coming to you. So this is basically a helminthic infestation with anemia. So you have to treat the anemia. You have to give anti-helminthics. You have to concentrate on his diet. All those basic things you have to do.
Sir, when we talk of anti-helminthics, how often do you advise anti-helminthics to be given to such children?
So, as per the national guidelines, at least twice in a year we are supposed to give. Every 6 months we are supposed to give. And in between, suppose the child is getting symptoms, so we can give.
Given little.
Yeah.
Thank you, sir. Thank you so much. So with this, we'll be concluding this very interesting panel. I must say I learned more while making the panel, and even more than that while conducting it. Thank you so much to my very esteemed and renowned panelists. Thank you so much. So I will end with our key messages. In our panel, we had discussed the importance of developing selective component resolved diagnostic panels in HDM, asthma, and allergic rhinitis, so that the child's treatment plan can be personalized. This kind of component resolved diagnostics helps to differentiate a true and cross-reactive allergen, which cannot be done when we're using whole extracts. We had thrown light on certain non-erogen manifestations of HDM allergy, like pancake syndrome, as well as a complete non-HDM allergy with a report showing a HDM allergy-like picture in worm infestation. So I hope all of you learned as much as I did from this panel. Thank you, Saibal sir. Thank you, Krishnamohan sir. Thank you, Dr. Karthik. Thank you so much.
Thank you so much.
Thank you.
Thank you, ma'am.
Alka, over to you. Thank you.
Thank you, Dr. Soundarya. Thank you, everyone, for being here tonight. And this is the first session on House Dust Mite Allergy, which has been truly enriching. A big thank you to Dr. Saibal Moitra, Dr. Krishna Mohan, Dr. Karthik, and Dr. Soundarya. Your insights on molecular diagnostics have been really useful, and how we can apply this in our Indian clinical practice, that was really invaluable. We had a great start, and I'm really excited about the next sessions ahead. See you all in the next one, which is on 15th May. And thank you and have a wonderful evening. Thank you, everyone. Thank you so much. Thank you, Dr. Neeraj. Thank you so much. We're
Thank
closing
you,
the session
madam.
now. Yeah.
Thank you, sir.
Yeah.
Thank you,
So
Sam.
yeah. So the conclusion. So at the end, I would really like to thank the entire team, the platform, and I hope that this was one of the initiative from the ISAs and everybody who has attended that. They must have been benefited from such excellent deliberations by Dr. Karthik, Dr. Krishna Mohan, such excellent panel moderation by Dr. Sandera. We will be having two more similar enlightening, rather enriching sessions on the CRD 2.0. And so I hope that you all join and you all get enriched, and you also make us to get ourselves enriched more in the way by interacting. It's a dialogue, it's a way forward altogether. We join hands. It's we are all in the same boat. So thank you all and very good night to everybody. So I would just like to pass on to Dheeraj to give the concluding remarks. Thank you.
Thank you, sir. I think it was really, as you said aptly, that it was a wonderful session, and I really enjoyed the session, and especially how you implemented all the knowledge which you imparted in the initial 1 hour, 15 minutes in the form of a panel discussion, especially the case-based discussion. So this was really needed and the need of the hour. So I think thank you once again, and thank you, Thermo Fisher, thank you, Alka, for giving us the platform, and we will look forward for the subsequent sessions also. Thank you.
Thank you so much, sir.
Thank you, sir. Thank you, ma'am. Good night.
Thank you, ma'am. Thank you. Bye.